This is Chapter 12, Part 1. We're going to talk about anti-infective drugs, antimicrobials, specifically antibiotics. In this part, in the next part, we'll talk about some other antiseptics and disinfectants and antifungals. We need to identify classes of anti-infective drugs, talk about adverse side effects, clinical uses, antiviral drugs, and then, like I said, in the part 2, we're going to talk about antifungal, disinfectants, and antiseptics. Some key terms for this whole chapter would be antibacterial versus antibiotic. Antibiotic means anti-life. Antimicrobial means anti-microbe. Now, both of those words, antibiotic and antimicrobial, can refer to antibacterial or antifungal or antiviral, because it's anti-life. Bacteria, we need to understand bacteria and the different forms of bacteria. Bactericidal versus bacteriostatic. Different drugs perform their jobs either by killing bacteria or by limiting their growth so the immune system can kick in. You need to know the difference between the drugs that do that. Beta-lactamase, we're going to talk about what that is and what that means for treatment. In this lecture, we are going to be talking about in vitro versus in vivo use of the drugs, a little bit about microorganisms. The rest of the key terms we'll talk about in part 2. Any break in the body's natural defense system will be a cause for infection. So the body's natural defense system has to do with the skin, the elasticity of the skin, the moisture content of the skin, the mucous membranes, making sure they're intact, the cilia in your reproductive tract, and in your respiratory tract as well. All of these things are part of our natural defense. Some microorganisms have pathogenic potential, but others do not. So some are actually good for our bodies and some are not. Animals usually make initial contact with an infectious agent somewhere on the body surface. That means mucous membranes, skin, respiratory tract, or digestive tract. When we stain for these microbes, so they can, if we get some of these microbes either by culture or on a smear, we can stain them and tell if they're gram-negative, gram-positive, acid-fast, or how they stain with Giemsa stains. Some organisms are cultured and they grow better in oxygen, so we call them aerobic organisms. Others grow without oxygen or better without oxygen, and those are called anaerobic. So if we can categorize the bacteria, it can help us to categorize what drugs we can use. Antimicrobial drugs can be divided into 2 categories. This is the first of many ways that we can categorize these medications. They can be bactericidal, which means that kills the bacteria, or bacteriostatic, which means it just retards the growth of the bacteria so that the immune system has time to work. Microorganisms that we're going to be talking about include bacteria, like these rods, or protozoa. These are rickettsial bacteria, or rickettsial organisms that are a little bit like bacteria and a little bit like protozoa. We will also talk about viruses, and then next part we'll talk about funguses. Antibiotics, as I said, are anti-life, anti-bio. So that includes antibacterials, antiviruses, antifungals, antiprotozoals, disinfectants, and antiseptics as well. Tamiflu is an antiviral medication. Antiviral medications are the only things that work against viruses. Otherwise, our immune system takes its time to fight the virus itself. The antiviral medication can help reduce the load of virus so that our immune system can kick in. This is why when we get the flu, if we can take Tamiflu within the first 3 days, we can have a shorter course of the virus, but it doesn't necessarily kill the virus. So our goals with antimicrobial treatment is to kill or disable the pathogens without killing the host. That's an important part to remember. we've got to do this very carefully. Antibiotic means anti-life, and that can be the life of the single-celled organism, or it can mean the life of the multicellular organism, like the animal that you're treating. We do have to figure out if the microorganism that we're trying to kill or disable is susceptible to the antimicrobial that is chosen. And how do we find this out? Culture and sensitivity. Very important. The antimicrobial must be able to reach the site of infection, or the tissue site, in high enough concentrations to kill or inhibit the microorganism. So tissue, where it accumulates in tissue, is really important. And the patient must be able to tolerate high concentrations. The antimicrobials rely on the patient's immune system, especially static drugs. We need a functional immune system if we're trying to defeat the microorganism with bacteriostatic drugs or fungistatic drugs. Some special considerations. We do not want to use antimicrobial drugs for a mild infection. Let your immune system work. The more your immune system works, the stronger it gets. Antimicrobials should be used only for individuals at risk of severe infection. You do not want to dismiss the principles of asepsis just because there are many antibiotics from which to choose. So asepsis is really important too. So we want our immune system to work. We also, bacteria their job is to live. And so if they can become resistant to antimicrobials, that's what they will do. So that's the other reason we don't want to use antibiotics for mild infections. The use of antimicrobials should be based on a definitive diagnosis. What is that? Culture and sensitivity. We don't want to use a broad-spectrum antibiotic if the infecting organism is sensitive to a specific antibiotic. So something that will kill it specifically is what we want to use. Antimicrobial drugs should be administered in full therapeutic doses, which means we don't want to give just a little bit, just to see if we can kill just a little bit of the bacteria. We want to kill all of the bacteria, and we want to do it for the entire time that the antibiotic is prescribed. If the antimicrobial can be used topically or locally, we want to do this. That reserves the use of systemic drugs for serious disease. And we also have to be careful of withdrawal times in animals to be slaughtered for human consumption and antibiotic withdrawal times in dairy cows. Antibiotics, they are most commonly obtained from growing microorganisms like bacteria or molds. These bacteria or molds will secrete endotoxins into their immediate surroundings to kill or inhibit the growth of other microbes. It's like if you have a not very friendly neighborhood. If you have a not very friendly neighborhood because there are neighbors there that prefer to keep other people who aren't like them out of the neighborhood, they're secreting these little endotoxins, and they're keeping those other people out of their neighborhood by inhibiting their ability to come into the neighborhood. Most of the antibiotics that we use are now chemically synthesized, but they did come from typically food or plant sources prior to being chemically synthesized. These are the classes of antibacterials that we are going to talk about. Some of these are also antiprotozoals. There are 1, 2, 3, 4, 5, 6, 7, 8 classes here, and you are going to need to know many drugs from each of these. So we're going to talk about them in terms. Will have similar attributes, and then you will know inside those classes you will be able to name certain drugs from inside of those classes. But this is how I want you to start to separate them. Penicillins, they are the first made, they're still the safest. These are ones that do develop a lot of resistance to. Bacteria does develop a lot of resistance to, so when we give it, make sure the animal is finishing all the medication. Penicillins do tend to precipitate in solution, and they need to be refrigerated. We want to dispose of it after 7 to 10 days after it's been mixed. This is something we shake well and keep in the refrigerator. So this is the sticker we'll put on most penicillins. We give it per-ROS, and if we do, they're absorbed in the stomach and the small intestine. If we inject it, it's quickly distributed to the tissues. We do have to be careful about withdrawal times. They are excreted through the milk. So if they're excreted through the milk, they will be really good to treat mastitis. How do they work? They bind reversibly, so we can reverse this. They bind reversibly with enzymes outside the bacterial cytoplasmic membrane, increasing the internal osmotic pressure and rupturing the cell. Here's the cell, and it is blowing apart. Okay, so penicillins blow apart the cells. This is metabolized in the liver and excreted in the kidneys. So again, it goes into the urine. It's something that we can use for urinary tract infections. Penicillins are not effective against beta-lactamase producing bacteria. Staphylococcus is a beta-lactamase producing bacteria. Beta-lactamase producing bacteria keep certain things from killing. It's how they protect themselves. Staph is one of those organisms that protect themselves by producing beta-lactamase. Okay, in order for penicillins to work to kill Staphylococcus or other bacteria like Staphylococcus, they must be what we call potentiated. They must be changed in order to kill beta-lactams. If you know anything about the antibiotics that we use in medicine, we know that there is something called CLAVULANATE. It's also known as, augmentin in human medicine. Amox stands for amoxicillin. Clav stands for clavulanic acid. That is how amoxicillin is potentiated to kill Staphylococcus as well. What are they effective against? Mostly gram-positive bacteria, but occasionally some gram-negative bacteria if they have an outer membrane around the cell wall that limits enzyme permeability. Some penicillins, so they're mostly effective against gram-positive, but some gram-negative as well. Some penicillins can penetrate gram-negative membranes to rupture the cell if they are able to get past those enzymes. Allergic reactions. So if any of you are allergic to penicillins or amoxicillin, you know about this. We'll see vomiting, diarrhea, if you take it on an empty stomach, or enteritis in cattle and horses if we give it orally. We want to avoid sub-Q injection of penicillin procaine G in food animals and avoid penicillin horses use for food. We have to check those food withdrawal times. Here are the withdrawal times. Can be up to a week for meat, 4 days for milk. If it's ampicillin, it's 2 days and 4 days. If it's penicillin G, it's 2 days and 4 to 8 days for the meat. Hives or respiratory distress if we have an anaphylactic reaction. And if we see that, we want to administer epinephrine stat. Here's amoxicillin plus clavulanic acid or clavulanate potassium or augmentin. It is a potentiated penicillin. Clavamox is a beta-lactam antibiotic plus this beta-lactamase inhibitor. It's broad spectrum because it can penetrate more of those gram-negative cells and Staphylococcus. We use it to treat skin, urinary tract, wounds, and respiratory infections. It's supplied as tablet and liquid forms for oral administration. If you've seen these tablets, they are in foil packs. Anything in foil packs is sensitive to light, and so you don't want to take it out of the foil pack until you're ready to give it to the pet. Again, once you mix this, we're going to get rid of it in 10 days. So if we have to give it for longer than 10 days, you're going to give them more than one bottle, and you're going to either show them how to mix it or have them bring it back for you to mix it. So that's penicillins. Ampicillin, amoxicillin, clavamox all fit into that category. Cephalosporins, anything that starts with this or has in it CEPH or CEF. These are similar to penicillins, And when we talk about cephalosporins, we have to talk about what generation they are. So the generation tells us their spectrum of activity. Are they gram-negative, gram-positive, broad spectrum? Tells us more about it. And it's generations 1 through 5. First generation tend to be more gram-positive, and each generation after that, second, 2, 3, 4, 5, has more gram-negative activity with a little bit of loss of the gram-positive activity, except for fourth generation, which has a broader spectrum. These are bactericidal. These work best against rapidly dividing cells. They are beta-lactam antibiotics that disrupt peptidoglycan formation in the cell wall. We can see a cross-reaction with people or pets that are allergic to penicillin. We'll also see allergic reaction with cephalosporins and also GI upset. Now, penicillin is bactericidal, kills the cell as well. Cephalosporins are also bactericidal, okay? Bactericidal medication works best, all of them work best if you have an bacteria that is rapidly dividing. So it's rapidly remaking itself, and that helps these antibiotics to find what they're supposed to kill. If you have an animal that you are giving a bacteriostatic medication to, that's actually slowing the growth, slowing the division of the cells. So you cannot give a bacteriostatic medication with a bactericidal medication and expect them both to work the way they're supposed to. You're not going to get the same activity from that bactericidal medication because it won't be able to find what it's looking for. Most cephalosporins are given by injection. They're best absorbed if you give it IM, but that is painful. We're going to use it for cystitis, skin and soft tissue infections in dogs and cats, bovine mastitis, shipping fever in cattle, and most of those are respiratory infections. So respiratory infections in cattle, horses, sheep, and swine. Also in day-old chicks and day-old turkey poults for control of early mortality associated with E. coli. These are metabolized in the liver, excreted in the kidney. Work really well. They do not cross the blood-brain barrier, but in general are well distributed. Here's an example of cephalosporins from pharmafacts.com. They're described as bactericidal. They're derived from a fungus. They disrupt peptidoglycan formation in the cell wall just like penicillins. They have no activity against these lame bacteria. Listeria, atypicals like Mycoplasma or Chlamydia, MRSA, or Enterococci. So except for MRSA, it can be susceptible to fifth generation cephalosporins. Some side effects: nausea, diarrhea, rash, pain, and inflammation at the injection site, cross-sensitivity, allergy with penicillins. Here are some examples of first generation, second generation, third and fourth kind of go together, and then fifth generation. And as we go this way, they're more gram-negative. As we come this way, they're effective against more gram-positive. And this one is the most broad spectrum. Next group, sulfonamides. This has to do with a sulfur compound contained within the organic molecule. Most sulfonamides are effective against protozoa like coccidia or giardia and foot rot or anaerobic bacteria. These are bacteriostatic. Now remember, you need to remember the difference between bactericidal versus bacteriostatic. The sulfonamides are all classified based on GI absorption. The way that these work is to interfere with folic acid synthesis, which has to do with growth and DNA and RNA. Now eventually that's going to affect the animals, so we don't want them on this long term. These are generally broad spectrum and antiprotozoal, and it gets good levels in the CSF, middle ear, bone. We'll get really good tissue concentrations in these hard to reach areas. We can see hives or sensitivity, skin sensitivity, vomiting, diarrhea, anorexia, fever, crystal formation within the kidneys, especially with carnivores. KCS with long-term use in dogs, so dry eye in dogs. We don't use it much in livestock except if we have foot rot. So urinary tract infections, respiratory tract infections, coccidiosis, wound infections, foot rot, pretty often used. Usually preferred for colitis therapy and with its anti-inflammatory effects. If you remember talking about GI, we talked about sulfasalazine and with diarrhea and how that has anti-inflammatory effects. I'm not going to spell that. Sulfasalazine, anti-inflammatory effects, and antibacterial effects. We do have to be careful when we give it with aspirin-like drugs with cats. Can cause bleeding disorders and ulcers. Some formulations would be Albon, SMZ-TMP, which is very common to give in horses, and Primor. Bactrim, you may have heard of Bactrim used in people for urinary tract infections. And it's a pretty common early medication that we'll use, and that is SMZ-TMP. So when we give it systemically, we do want to give it parenterally, so inject it. If you can, it is metabolized by the liver, excreted by the kidneys. Do have to be careful when we use it in ruminants because of withdrawal times. And we also want to make sure that that patient is well hydrated when we give it. Our next group are tetracyclines. Tetracyclines end in cycline. They're given parenterally, so by injection, topically, like eyes or ears, and orally. These are broad spectrum. They get both gram-negative and gram-positive, but many bacteria are resistant to a lot of these drugs. Doxycycline is the most common tetracycline used in small animals. Something very similar to doxycycline is minocycline. What do they treat? Borrelia, which is a spirochete. It's this spirally bacteria that you can see that is actually mobile, and that causes Lyme disease. We also use these for rickettsial diseases like Ehrlichia, which causes Potomac horse fever and Rocky Mountain spotted fever. So it's bacteriostatic. It binds with microbial ribosomes. It interferes with RNA synthesis, so it interferes with cellular division. So if you look at the static drugs, they are interfering with DNA and RNA. Okay. It can be used with chlamydia, ocular disease. Very often see that used with cats, and it can be anti-inflammatory, especially that tetracycline or terramycin. With birds that get chlamydia, often we see respiratory disease, GI, and systemic disease. Remember that chlamydia does have a zoonotic potential. We can also see it being used with mycoplasms, which are really hard to kill because that shell, that mycolic acid that's around the cell wall, which causes respiratory disease, pneumonia, bovine mastitis, and we can also see it with Hemobartonella, which is cat scratch fever. So Lyme disease, Ehrlichia, chlamydia, mycoplasma, Hemobartonella, these are all difficult to kill microorganisms. It is well distributed and crosses the placenta and passes into the milk. We do have to be careful about that. It is hydrophilic, so especially tetracycline and oxytetracycline, but the lipophilic ones, like doxycycline, have a longer half-life, so you don't have to give it as often, and better tissue penetration. The absorption of tetracyclines is dramatically decreased by the presence of food, milk products, and antacids. So do not give with food. Do not give with food, okay? Now just do not food, especially dairy, tetracyclines, very sensitive to that, and antacids. They can cause cardiac arrhythmia and calcium binding. We have to be careful with digoxin as well, right? So it can retard bone growth, it can stain enamel, and can cause milk fever in cattle. Some don'ts, okay? Don't give it with dairy, don't give it with iron, don't give it with oral antacids, antidiarrheal agents, Pepto-Bismol or Imodium. Patient cannot have a deficiency or be on any of these supplements, calcium, copper, iron, and magnesium, because it interferes with the metabolism of those. Never give tetracycline IV to a horse, and it's not approved for use in lactating dairy animals or poultry that produce eggs for human consumption. Our next group are aminoglycosides. These end in mycin or mycin. So streptomycin, gentamicin, neomycin, amikacin, okay, that's a little different, which is the injectable form. A triple threat when we give a topical antibiotic often includes an polymycin. It is bactericidal. It prevents normal protein synthesis. It is broad spectrum. It is hydrophilic at most pHs. It is nephrotoxic. You have to have healthy kidneys to give it. And we have to have normal hydration. We have to be careful how long and how much of it we give. It is also ototoxic. This can be irreversible, especially in cats. We have to be very careful when we're using these drugs in the ears, especially of working dogs, because they need their hearing. So we'll often see hearing loss, but also vestibular signs with that ototoxicity. So nephrotoxic, ototoxic, and cardiotoxic. So it blocks the use of calcium, prevents the uptake of calcium, decreased ability for the heart to contract. And if we give it with cephalosporin, we see an increased risk of that. We will use it to treat patients that the bacteria is susceptible to these aminoglycosides. We treat patients with pneumonia, endometritis, urinary tract infection, bacterial enteritis, conjunctivitis, topically in the eyes, skin and soft tissue infections. It does have good systemic absorption with denuded skin, so I can put it on skin that is abrased or it has good blood flow right to that area, and so it will get directly into the body that way. We do see high concentrations in extracellular fluid because it is hydrophilic. We see accumulations occurring in the inner ear and the kidney. That's what leads to the toxicity there. And bacteria do develop resistance to a single antibiotic easily, which is why we usually mix it with other things, but not cephalosporin. Don't usually give this orally. It's either topical or injection, or we use it as an infusion to put directly into the uterus, the mammary gland, the bladder, or injection, and it is excreted by the kidneys. Our next group are fluoroquinolones or quinolones. The bioavailability is greater than 80% in 1 to 2 hours in dogs, even paras. So these are highly, highly, highly effective, get into high concentrations in the tissue. They get in very easily. These are enrofloxacin, orbifloxacin, ciprofloxacin, Baytril, Orbax, Cipro. They're bactericidal. They're broad spectrum, gram-negative and gram-positive, especially aerobic bacteria. They can cause lesions in the articular cartilage during rapid growth phases of dogs, and they increase the possibility that they are going to close the growth plates earlier. So we do not recommend this. It's contraindicated in dogs less than 6 months of age. I do not recommend it. So we originally used it as a coccidiostat, but now we use it in dogs, cats, poultry, and cattle, but not in horses. Do not use it in horses. It gets to therapeutic concentrations very easily in bone, aqueous humor, prostate, skin, CSF, and placenta, so it crosses all those barriers. We can see vomiting and diarrhea or seizures if patients have previously had seizures. We also get high concentrations in the liver, lung, and kidney. We do not want to use it for cattle intended for dairy or for veal calves, or in laying hens that produce eggs for human consumption, because we don't want to produce resistant bacteria to these drugs. They're highly effective drugs. They're probably one of the last drugs that I'll choose When I'm starting to treat something empirically, I'm going to start with amoxicillin or clavamox, and I'll kind of move up from there. But fluoroquinolones are going to be my last choice in most cases. Macrolides. Now this is a little different category, because within this category we have two groups. We have erythromycin and lacosamide and clindamycin. So on this side we have erythromycin. One of the forms of erythromycin is tylosin or Tylan. Both of these drugs get gram-positive and some anaerobes, so for foot rot. In birds, it gets mycoplasma bacteria. These are bacteriostatic. They are both well distributed in the prostate and the placenta with high concentrations in the milk, saliva, and lungs. Does not cross the blood-brain barrier. So erythromycin we use for upper respiratory tract, mastitis, metritis, so reproductive tract, foot rot, if it's susceptible, and for skin infections. It has a similar spectrum to penicillins. It's excreted in the feces, so it can cause colitis in dogs and cats. So we have to be careful of that. So that's different. Most drugs are excreted in the urinary tract. This is excreted in the feces, and that's why we can use it for IBD or overgrowth of bacteria in the intestinal tract. Lincosamide and clindamycin are effective for lower respiratory tract infections, so pneumonia, skin infections, oral infections, and Clostridium difficile infection. These are excreted mainly in the kidney. So even though these are in the same large, broad category, they are slightly different. They have similarities, but there are some differences that you should know. Okay, lastly, we have chloramphenicol. This is a broad spectrum, gets gram-negative, gram-positive, aerobes, and anaerobes. Yay, it gets almost everything. That's great, but it's banned for use in food animal in the USA, including in milk. It's bacteriostatic in low levels and bactericidal in high doses. There are a number of different forms like oral, injectable, topical, ophthalmic, and otic. We commonly use it in pocket pets, birds, and reptiles. Don't very often use it in like mammalian animals. It is highly lipophilic and crosses the blood-brain barrier, globe of the eye, and the prostate. We have to be very careful in liver diseased patients because it has poor liver metabolism of the drug and can cause bone marrow suppression. Anybody administering it or counting out the tablets must wear gloves because it can cause fatal aplastic anemia, meaning you no longer make red blood cells. That is a problem, and you never will again. So that is fatal. Okay, so you want to wear gloves with chloramphenicol. Cats and neonates require much lower dosing. So we don't see this used often except ophthalmic and otic uses, but when we do see it, please wear your gloves. If you have any questions about these antimicrobials, let me know. Otherwise, go ahead and start on part 2, which is antifungals, antiseptics, and disinfectants.